Hi guys, it's me, Ira. So I'll be presenting to you this rare case of staphylococcal toxic shock syndrome in a lactating mother with breast abscess. So the causative agent of this TSS is Staphylococcus aureus. So this case study is from Kathmandu, Nepal. Today I'll be discussing to you the Staphylococcus aureus as well as the staphylococcal toxic shock syndrome, which is caused by the toxins that are produced by the S. aureus, then the pathogenesis of the TSS, the background of the case, the investigation such as blood tests that they did for them to come up such diagnosis, and the course of treatment and the outcome of that treatment. Staphylococcus is a genus of gram-positive aerobic bacteria in the family Staphylococcaceae. This genus of bacterium includes many pathogenic kinds such as the Staphylococcus aureus and may cause pus formation especially in the skin and mucous membranes. Staphylococcal infection can be transmitted by direct contact with infected persons. It may enter through a cut, burn or other injury or any wound and may cause a localized or spreading infection. Staphylococcal infection typically causes skin infections and sometimes pneumonia, endocarditis, and osteomyelitis. Staphylococcal infection commonly leads to abscess formation. There are some strains of Staphylococcus aureus that may form elaborate toxins that cause gastroenteritis and the toxic shock syndrome. Staphylococcal toxic shock syndrome or TSS is caused by the staphylococcal toxins that are produced by the S. aureus bacteria, particularly the TSS toxin 1 and other enterotoxins. Staphylococcal TSS can be menstrual related or non-menstrual related. Menstrual related if there is a pre-existing vaginal colonization due to the use of tampons or contraceptive sponges and leaving it there. On the other hand, non-menstrual TSS can occur in association with primary Staphylococcus aureus infections, including post-surgical, postpartum, or post-abortion infection, burns, focal infections such as pneumonia or antecedent influenza infection. Staphylococcal TSS is defined by clinical and laboratory evidence of high fever, erythematous rash, desquamation, particularly on soles and palms, hypotension, elevated creatinine kinase, mucositis, myalgia, thrombocytopenia, confusion, and multiple organ failure. TSS has an annual incidence in adults of 11 per 100,000 people in the United States. The isolation of methicillin-resistant Staphylococcus aureus or MRSA strains causing TSS is very rare. The mortality rate in adult patients is about 30 to 80%, which is pretty high. Staphylococcal TSS is a superantigen-mediated disease. Superantigens are a group of proteins that can activate the immune system by bypassing certain steps in the usual antigen-mediated immune response sequence. Superantigens are not processed within the antigen-presenting cell before being presented to T cells. Instead, they bind directly to molecules of MHC class II, which requires recognition of only one element of the T cell receptor to trigger a massive T cell activation. After binding to T cell receptors and MHC class II molecules on antigen-presenting cells, superantigens trigger T cell activation that results in the release of cytokines, which includes tumor necrosis factor alpha, IL-6, interferon gamma, IL-2. Other results of T cell activation are recruitment of further T and B cells to the site of infection and co-activation of the antigen-presenting cell, resulting in the further release of mediators such as IL-1 and TNF-alpha. Massive cytokine release is believed to be responsible for the most severe features of TSS such as fever, hypotension, tissue injury, and shock. A 19-year-old female was brought to the emergency department with the chief complaint of fever with altered level of consciousness. She also had a history of nausea, vomiting, and diarrhea for 5 days. The patient further complained of pain on her left breast. Her urine output was less than usual. She had a history of normal vaginal delivery 8 weeks ago and was breastfeeding her child. Otherwise, she did not have any significant past medical and surgical history. She was non-smoker and non-diabetic, and she was not taking any immunosuppressive drugs. Here are the vital signs and other observations on presentation to emergency department. The patient was hypotensive with a blood pressure of 80 over 60 millimeters of mercury. Her heart rate was elevated, which was 98 beats per minute. Her respiratory rate, which was 20 breaths per minute, which is within the normal range. She also had a fever with a temperature of 102.08 degrees Fahrenheit. The patient was also drowsy and confused with a Glasgow Coma scale of E3V4M6. Her eyes and mucosa were dry. She also had a capillary refill time of more than 3 seconds, which was not normal, so this may indicate the presence of circulatory shock. The patient was also jaundiced. Glasgow Coma Scale is used to assess the level of consciousness of a person in response to a defined stimuli. It is divided into three parts: the eye-opening response, verbal response, and motor response. So here's an example of the criterion in which you could refer for you to give scores to the patient. Physical examinations were also done to the patient. An abdominal examination revealed minimal tenderness in the right upper quadrant with no peritoneal signs. A breast examination revealed mild tenderness in the right outer quadrant of her left breast. It showed signs of inflammation on the overlying skin but no obvious discharge. Her pelvic examination revealed no vaginal tenderness and any vaginal discharge were absent. The patient developed desquamation on her palms and soles. So here's a picture of the desquamation of her soles, and the other one is on her palms. Various laboratory evaluations were done, and here are the following results of her labs. The patient's white blood cell count is higher than normal, so this is referred to as leukocytosis, which may be due to infections that are most commonly caused by bacteria or inflammatory diseases or tissue damage. Her hematocrit, hemoglobin, and platelet counts, on the other hand, were normal. Her creatinine and blood urea nitrogen were elevated, so this means that there might be something wrong with her kidney function. Her glucose were also normal. Her blood pH, on the other hand, is lower than normal, so this is referred to as acidosis. Her lactate levels were also low. Her total bilirubin, direct bilirubin, aspartate aminotransferase, alanine aminotransferase labs are elevated. So this means that there is something wrong with her hepatic function. Her prothrombin time, INR, or international normalized ratio, and activated partial thromboplastin time were normal. So this is a blood test that measures the time it takes for the liquid portion or plasma of your blood to clot. Usually, PT is reported as INR in most laboratories because INR is the standardized results of prothrombin times. A chest x-ray was done and the results were normal. Lumbar puncture was also performed and the CSF revealed no abnormal cytological or biochemical changes. An ultrasonography revealed a cystic area of 2 by 2 by 1 centimeters with tenderness. And culture sensitivity was also done from the pus of breast abscess, and it showed that it contains Staphylococcus aureus that is sensitive to chloramphenicol, ciprofloxacin, levofloxacin, moxifloxacin, trimethoprim, clindamycin, erythromycin, gentamicin, and vancomycin. Moreover, the sensitivity report also showed that it is resistant to methicillin and piperacillin tazobactam. The blood culture, urine culture, and vaginal swab culture showed no growth. So here is a photo of an ultrasonography, and the other one is a photo for lumbar puncture, how it's done, and where is the needle inserted. These are the following criteria used for the diagnosis of staphylococcal TSS, which are based from the Centers for Disease Control and Prevention, or CDC. A fever should have a temperature of greater than or equal to 102 degrees Fahrenheit. There should be rash, disclamation, hypotension, multi-system involvement, should be three or more of the following organ systems, including gastrointestinal, muscular, mucous membrane, renal, hepatic, hematologic, or central nervous system. Identification of Staphylococcus aureus on cultures is also required. Moreover, exclusion of other etiologies from cerebrospinal fluid studies or blood cultures should be performed to rule out other bacterial infections such as streptococcal infections, rickettsia, leptospirosis, and viral infections. Using the criteria of CDC, the patient was diagnosed with staphylococcal TSS. She presented with temperature of 102.08 degrees Fahrenheit. She was hypotensive. There was multi-system involvement, including gastrointestinal, renal, hepatic, and central nervous system. Also, her culture showed MRSA, or methicillin-resistant Staphylococcus aureus. Then, there were negative results for her cerebrospinal cultures. Lastly, there was desquamation on both of her soles and both of her palms. Management of the patient's condition includes the fluid resuscitation with 1.5 of a fluid bolus of normal saline. This was an attempt to increase her blood pressure and tissue perfusion, but there were no signs of improvement. So they gave her vasopressors, noradrenaline, and adrenaline. So vasopressors are medicines that constrict blood vessels, increasing blood pressures. They are used in treatment of extremely low blood pressure or hypotension. Next, the patient was started on antibiotic therapy with piperacillin tazobactam. The patient was then transferred to the ICU. So after the confirmation of her breast abscess through ultrasonography and aspiration, an incision and drainage of her left breast was performed at the bedside under local anesthesia with intravenous supplemental opioid analgesia. Then, her antibiotic regimen was adjusted after the culture results came in. The patient was started on vancomycin since the isolated bacteria was MRSA and clindamycin. So the patient showed clinical improvement and her renal and hepatic functions were normalized. She was discharged on clindamycin 2 weeks after her admission to the hospital. She was completely asymptomatic on her follow-up visit after a week of her discharge. Patients with the highest risk for menstrual staphylococcal TSS are female patients with pre-existing staphylococcal vaginal colonization who use and leave tampons, contraceptive sponges, or diaphragms in their vagina. On the other hand, patients with risk for non-menstrual staphylococcal TSS occur in patients with burns, soft tissue injuries, retained nasal packing, post-abortion, post-surgical, postpartum, post-intrauterine device placement, and abscess formation. In non-menstrual TSS, its risk factors include colonization of toxin-producing strain of S. aureus, protective antitoxin antibodies are absent in an infected site. So for this case study, it is a non-menstrual related case. TSS early detection is important to immediately provide the appropriate course of treatment, which includes the prompt drainage of the site of infection to control the production of toxin. Moreover, antimicrobial therapy with appropriate antibiotics from the culture analysis must be used, such as clindamycin to inhibit toxin production and vancomycin if the causative agent is MRSA. Also, supportive therapy such as fluid resuscitation and pressor support if needed. This is the first reported case to document the fulminant course of staphylococcal TSS on a lactating mother with a breast abscess. Thank you for listening.